Fulminant hepatic failure. Fulminant hepatic failure is the clinical syndrome of sudden and severely impaired liver function in a previously healthy person. According to the original and generally accepted definition, fulminant hepatic failure develops within 8 weeks of the first symptoms of jaundice. There are three categories are frequently cited: hyperacute, acute, and subacute liver failure. In hyperacute liver failure, the duration of jaundice before the onset of encephalopathy is 0 to 7 days. In acute liver failure, it is 8 to 28 days. And in subacute liver failure, it is 28 to 72 days. The prognosis of fulminant hepatic failure is much worse than the chronic liver failure. However, in fulminant failure, the hepatic lesion is potentially reversible with survival rates of approximately 50 to 85%. Survival rates depend greatly on the etiology of liver failure. Those who do not survive die of massive hepatocellular injury and necrosis. Viral hepatitis is a common cause of fulminant hepatic failure. Other causes include toxic medications, example acetaminophen, and chemicals, example carbon tetrachloride. Metabolic disturbances, Wilson's disease, that is a hereditary syndrome with deposition of copper in the liver, and structural changes, Budd-Chiari syndrome, Buddchiari, Budd-Chiari syndrome, that is an obstruction to outflow in major hepatic veins. Jaundice and profound anorexia may be initial reasons the patient seeks healthcare. Fulminant hepatic failure is often accompanied by coagulation defects, renal failure, and electrolyte disturbances, infection, hypoglycemia, encephalopathy, and cerebral edema. Management. Treatment modalities may include plasma exchanges, that is plasmapheresis, or charcoal hemoperfusion for the removal of potentially harmful metabolites. The acronyms ELAD, ELAD, that is extracorporeal liver assist devices, and BAL, bioartificial liver, have been used to describe these hybrid devices. These temporary devices help patients to survive until transplantation is possible. The BAL, that is bioartificial liver, exposes separated plasma to the cartridge containing porcine liver cells after the plasma has flowed through a charcoal column that removes substances toxic to hepatocytes. The ELAD, extracorporeal liver assist device, ELAD device, exposes whole blood to cartridge containing human hepatoblastoma cells, resulting in removal of toxic substances. There is a high risk of cerebral edema and life-threatening complication in patients with fulminant liver failure with stage 4 encephalopathy. The cause is not fully understood, although disruption of the blood-brain barrier and plasma leaking into the cerebrospinal fluid has been proposed as one of the theory. These patients require intracranial pressure monitoring. Measures to promote adequate cerebral perfusion include careful fluid balance and hemodynamic assessments, a quiet environment, and diuresis with mannitol, an osmotic diuretic. To prevent surges in intracranial pressure related to agitation, barbiturate anesthesia or pharmacologic paralysis and sedation are indicated. Other support measures include monitoring for and treating hypoglycemia, coagulopathies, and infection. Despite these treatment modalities, the mortality rate remains high. Liver transplantation has become the treatment of choice for fulminant hepatic failure. Thank you.